Okay, we're going to move on now to Claire Thomas. Claire is the lead for antimicrobial stewardship and a consultant in infectious diseases and clinical microbiology. She is also an honorary senior lecturer at the University of Southampton, and she's going to talk to us about the SIREN study.
Hi, thanks very much. I'm just going to speak to you. Can you hear me?
Yep, we can.
Emma's laptop, having had a few IT issues at home, so I've cycled up the hill to Winchester. My reflection is that we're all learning how to speak with masks on to assembled audiences. I just want to thank the organisers, to Emma, Claire, James for today. Huge effort, absolutely wonderful. And I'm here just to talk briefly about the amazing NHS staff study that many of you have personally been involved in. And as Arthur says, this has been the most incredible experience for all of us, contributing on the side, to various studies. I'm a patient, as it were, at an Oxford study. And it's just a huge privilege to be able to contribute to what is, the first pandemic of really living memory for me, apart from Ebola, and yeah, really quite extraordinary. So SIREN stands for SARS-CoV Immunity and Reinfection Evaluation. And really to say that the work of the clinical research team has been absolutely extraordinary, because the ask, when we asked them if they could do this, came when they were setting up recovery, looking at recap map. We were still in the first surge. So I really wanted to thank the team enormously for taking this on. And the core team are wonderful: Judith, Liz, Ina, Tripanema, Sammy, and the amazing IT team. And I can't forget the microbiology lab and all the work that's gone in there with Helen Denham leading that. So as you all know, a new respiratory illness started peaking up. We first started to know about it towards the end of December 2019. And those of us in the infectious disease and microbiology world have been waiting for the new coronavirus to come out of Asia, because SARS back in 2003 died a death, and we don't know why. And just to remind everybody, with SARS-1, 860 people passed away worldwide. And if you look at the millions that have been affected around the world now, it's the coronavirus, but it's a different coronavirus. We knew it had pandemic potential. We knew in January there was about 89% homology to SARS-1, and there was huge preparation that started within our trust, locally, regionally, and nationally, to start to prepare ourselves for this new enemy. Now, the first cases, as Nick will know, who's on this call, started to perk up around us in February 2020, and they were locally introduced from the February half term, so quite interesting, phoning all those positives through. And the key thing is, back in January, we developed our own PCR with our amazing clinical scientist, Steve Kidd. And really just huge clap to Steve, because none of these trials would have been possible without us asking for the early PCR and all the work that's been therefore developed by the LAMP team, etc. Nick's going to talk about that. And I think we're one of the first NHS hospitals to actually have our own in-house PCR that was verified with some difficulty with PHE. So we started to test within the trust in February, which really gave us the end of February, March, which really gave us the huge ability to push forward with these research trials. Now, as this was a new virus, there's a clinical need to understand the clinical impact, what was the morbidity and mortality in the different groups? How would it affect our healthcare workers? What was the immunity? What did immunity look like? Did it last for a few weeks? Because people didn't know too much about coronaviruses. Did it last for months? And there's a huge opportunity to look at us, it's a very large cohort of UK NHS workers who are working frontline, seeing patients at all stages of their presentation. And if there was to be a future vaccine, and back March last year, people obviously were working on it, but we had no idea that we would have a vaccine this rapidly. Would it be effective, and what did short-term, long-term immunity look like? And if there would be any immunity against the variants? So Nick's going to elaborate a bit more on the lab testing, but just to say that our first test that we offered that was validated based on the Wunan, as it was sequenced, was an RT-PCR. And the best samples that we realized, sadly, as you've all been through, was rather a deep nasopharyngeal swab. We've all been doing nasal swabs with the lateral flows. But obviously, these are all quite tricky, and huge thanks to all participants who've been going through this. And just to reiterate, when we started this March, April last year, there were no serological tests looking for antibodies available. So I won't elaborate too much on this, but essentially what we were showing with our assay is that we were swabbing people at day 3 of illness. We pulled back to day 1, and we were looking at high sensitivity specificity with the polymerase chain reaction in the high 90s. And obviously at that time, it was a new virus, we were looking at the diagnostics, we weren't quite sure about sensitivity specificity. So really the SIREN came out of British Infection Association chat, and this is really where what we found is you reach out to colleagues at the national, international, local level to say, guys, we've got this, what's going on? We're doing all the basics here. Is there anything else we can do? And Susan Hopkins, who's an old colleague in London working at the Royal Free, who's now one of the main ID doctors heading up PHE and public health efforts at national level, started to talk about SIREN. And so we spoke early with her, and essentially we were one of the first hospitals in the country to express early interest. It did take us a while to get set up because we were in the middle of obviously recovery, recap, map, etc. And their thoughts were at that stage, it was estimated that between 20 and 30% of frontline staff were likely to be seropositive in May 2020. This is pre all the antibody work coming through. And so it was thought this would be a great pool of people to recruit. And they hoped initially for about 30 to 40 sites, up to 50. And they wanted about 500 staff at each site if possible. So the idea was to recruit us for at least a year and study our immune responses to COVID-19 and to collect history on how it presented. You know, were we asymptomatic? Was there a cough? Was there the classical nausea that was becoming to be seen as a thing? Was it very mild symptoms? And certainly when I was direct infection control, we were very keen because we were seeing as we went along people presenting asymptomatically, as it were, with just a bit of a cold, a bit of a runny nose, with a bit of the fever was only in a certain proportion of people, and with myalgia. So essentially what we were asking is blood samples in this trial to be taken every other week, and I'm really grateful for everybody to go through that. And all NH staff who deliver any care to patients were being asked if they were coming forward for the trial to have a swab every other week. And of course, you would be getting your results from that. And the key questions were, do these antibodies give protection? And if we can pick up the antibodies, how long do they last post-infection? What was the impact or the future impact of COVID-19 on the healthcare workers? And in that, we're looking at long COVID and by inference on the general population. And at this point, the vaccine was not mentioned. It was totally aspirational. And it was designed as a longitudinal cohort study at trusts around the country. And this is all the fine detail, but primarily, the main outcome was to determine if SARS-2 infection confers future immunity to reinfection healthcare workers. And there are quite a number of secondary outcomes. And the other thing was also at the bottom, which is really important, to look at between disease severity and neutralizing antibody production, see if there was a relationship there. And as sequencing's come in, all samples now are sequenced, and SIREN through COG UK has been sequencing. And this is a particular area of interest with our new VOC, our variants of interest, with the new Indian variants coming through. So how was it rolled out? Just aware of time. The clinical research team has been absolutely fantastic. The lab, as you can imagine, was under huge pressure. So to be able to support a national clinical trial involving staff at this particular point was exceptional. And I can only take my hat off several times to Helen and the team. Our IT guru, Sean Goldsmith, was exceptional here with all the ICE requesting. Comms were fabulous, rolling it out, saying, do you want to be involved? It's a national study. It's going to inform what's happening on the public health side. And there was a huge response. And we recruited, in the end, 348 staff. So really quite exceptional. And overall, we've got 44,000 participants across the whole of the UK, which does make it one of the largest studies in the world of healthcare staff. And so the recruitment update as of April is up. We're part of 134 trusts. And actually, where we are now is what's been absolutely brilliant, and it wasn't realized at the inception of this, is as the vaccine started to roll out, you could see the antibody response to the vaccines, and that started to inform the public health efforts around rolling out the vaccine. Recruitment has closed, but there are thoughts that we can keep this rolling. Susan and the team are discussing this, particularly with new variants, to see how long does immunity last for in those who are double vaccinated. And there's also this fantastic study that we've not directly been involved in, looking at T-cell immunity. And is T-cell immunity more indicative than antibodies against COVID-19? So really fantastic. So number of participants by week is thus, and just in Hampshire hospitals, we've essentially had 3 surges. Our first surge peaked at the end of March, beginning of April, and we started to, COVID started to pop up again in September, October. Our numbers started to come down beginning of December, and as the new variant kicked in, it went off again. So we're just rolling out of our 3rd surge, but a 2nd surge for the country. So the opportunities and challenges have been that the clinical research team, having been mainly sort of GI cancer, well, quite a lot of that work was paused during the pandemic, have just been exceptionally moving into infection studies, which is really fantastic. And I would like to see this carrying on, you know, but also to include the GI cancer studies as well. I think there can be a lot of cross-fertilization there. And it just shows the unprecedented effect that translational research, rapid research, has been able to do in a pandemic. I mean, this is unprecedented in modern times. The challenges have been that the poor guys have had to move the clinic around several times, particularly at Winchester. And I think I would plead with a modernising hospital campaign that if we do go into a research hub, that we have one area that we can do research in, that we can have our clinics in, because it has been quite stressful on the team. And I want to thank Judith and the team for their support there. So we've had a lot of feedback. I couldn't put it all on here. And one bit of feedback I got last night from a colleague was it was very good to get my results so I could show my dentist, because, you know, the humanity of this outbreak is that quite a few of us who need to attend the hairdresser from time to time haven't been able to do it, obviously, but the dentist has been the thing. So it's about the humanity as well. And we're very glad to hear that everyone's been very, you know, feedback as the whole team's been friendly, skilled and professional. And I think for me as well, because I'm contributing to something small in Oxford as a patient, it feels good to be contributing in a small way to the science around controlling this virus. It feels rewarding to be part of such an important study. And of course, the negatives are having these awful swabs. You know, having something stuffed up my nose, it became very delicate times. And I totally understand this, and I'm with you, you know. And I think the work that's been done in the lab by Nick and Helen and everybody and Steve around looking at saliva, which has been rolled out as well, is exceptional. So outcomes so far. So what's happened essentially is we've moved with the time. There's improved lab testing. We were the first in the country to use LAMP in SIREN. We're still following people up. SIREN looks as though it may well extend study. We're still learning, particularly around the VOX, the variants of interest. We don't have individual site data so far, but noted actually as we were going along that some colleagues were getting reinfected, but with less severe disease. We noted that people who were able to produce antibodies, because not everybody was able to produce antibodies, particularly with our different assays, were at, say, as the antibody levels dipped down, as the R number went up, they then got a second infection with COVID. National data has really helped looking at asymptomatic carriage in healthcare workers, and it's helped with our PPE advice and public health measures. And it also helped with the national COVID status. We saw a rise in autumn 2020. It's helped decisions coming out of our public health colleagues. And the crucial thing really now is how are the vaccines behaving in healthcare workers? Are we producing antibodies short-term, long-term? And I think this is going to be a big area for follow-up with SIREN. And I just wanted to say is just a huge thanks. It's a huge local effort, which has informed national, international efforts to combat this new virus. So just wanted to thank everybody. Thank you.
Brilliant, Claire. Thank you. That was excellent, as we knew it would be. You've talked about the humanity of COVID, and sort of we are on a spotlight on research, and I just wondered whether you could give us your personal spotlight on this emotional and challenging year for all of us, either with you to the research or even just, as you say, from the humanity of the situation. What's been your high point and what's been your low point over the last year?
So I think when we realised we were in trouble, which was beginning of really the middle of January, we could see things are happening because I've been very privileged. I've worked globally. I've worked in Asia. I was head of the SARS infectious disease unit, Singapore General. So you're always ready. You're always perking up. And Nick will attest to this. We always teach fever and returning traveller. The new coronavirus will come sometime out of Asia because nobody understood why SARS-1 burnt out. But I think the adrenaline started kicking in January. And at that point, I was Director of Infection Control. I met with our procurement guys, and we realized actually, this is the key thing, is that we couldn't get drugs off a clinical trial in February. And we started to, we set up an MDT with our amazing ICU colleagues, respiratory colleagues every single day for ITU, HDU. And we were working very carefully with the strategic guys, but we knew we couldn't do anything without clinical research because we didn't know what drugs worked. We were all scouring the literature. Nick was scouring the literature. And actually, we managed to meet with Dr. Partridge and Arthur very early on to say, look, we've got to keep the research team going. Lara was extremely supportive. And from that, everything just evolved, and recovery was went through in 6 days. It's extraordinary. You've got recap MAP, we then had SIREN. And I just think the adrenaline and the absolute desire and need to do something for our patients with this new virus was exceptional. I think the low points are when you're on an IT round, you know you're losing somebody. But I think the fundamental truth is we know that in Hampshire hospitals, we have done our absolute best, you know. The research capacity has gone from really, really good to absolutely fantastic. And I think we need to build on that. And I think if I was a patient coming into the trust, knowing that we were actively involved in research and at the forefront of looking for new treatments for COVID and beyond, because there will be more COVIDs behind this, is extremely reassuring. And I think it bodes very, very, very well for the hospital of the future and now.
Thank you. Beautifully put. Claire, that was really wonderful. Thank you. You've mentioned